It's my pleasure to introduce to you a panel that will discuss some healthcare and also some collaborative issues this afternoon. And what we know about healthy communities is that healthy communities are often made up of healthy individuals, and not just healthy individuals from the standpoint of physical health, but also mental health, spiritual health, and economic health. So this afternoon, I'm happy to introduce to you Michael Burnett, who is the Chief Administrative Officer with Piedmont Fayette Hospital. Next to him is Cheryl Watford, the Executive Director of Fayette Care Clinic, and seated next to her is Debbie Britt, the Executive Director of Public Relations, Community Management and Public Relations. Director of Community and Public Relations with Piedmont Fayette Hospital. And they're going to continue to share with you some aspects of healthcare that I think you'll find interesting.
Let me start off with just sharing a little bit about Piedmont Fayette Hospital. We just had our 15th anniversary, so we're now in those awkward teenage years as far as a hospital, just like kids as well. We are a private, not-for-profit organization, which means that we don't receive any tax dollars from the county or other authorities. Like a lot of other hospitals, they rely on county support. So we are fully private, and as a part of Piedmont Healthcare, we're able to do that. Along with that, we just last year we had about over $10 million of indigent charity care provided into this community as well. Folks that without insurance, that sort of thing as well. We'll walk through some of that in a little bit. We're licensed for 157 beds. We employ over 1,400 FTEs. And as Matt, I think he had to leave. I believe that might be I know it's in the top 5, if not the largest employer in the county as well. We have over 250 volunteers, as well as over 525 physicians on our medical staff. One of the things we're proud of, we've been recognized 5 times now as one of the top 100 hospitals in the country, and only one other hospital in the state of Georgia has done that 5 times. So we're fairly excited and proud of that as well. From an economic standpoint, I want to mention this last bullet down here. The Georgia Hospital Association does some economic impact studies that they look into the community. With us being the largest employer, they estimate that we've had from a job creation standpoint, just under 3,000 additional total jobs created in this community. And when you think about around the hospital, all the physician offices and all their staff and everything else that comes with that, the spinoff from that is there. But the total, kind of the neat thing is the total household earnings created was almost $150 million. When you look at our payroll last year, it was just under $80 million. You can see that what that does as far as a community, and why a lot of hospitals are sometimes the economic engines, in particular a lot of rural communities as well, you see a lot of that. So just a little bit on our volume. The one thing I want to point out, if you look at some of our volume indicators, particularly our ER visits here, last year we saw just about 62,000 ER visits. That is more than Piedmont Downtown. They see roughly 50. We have grown tremendously as well. And when you look at it from where these patients are coming from, you can see this is our inpatient market share. So about 35% of our inpatients, those that stay in a bed, come from Fayette County. You can see Coweta, South Fulton, Clayton. You can see the distribution of where that goes. We see the same thing in our ER, with only 37% of our patients coming from Fayette County. Actually, 17% come from South Fulton. We've started to get more of a draw of people driving south rather than going north for health care. A lot of folks ask about the impact of the Piedmont Noonan Hospital and the opening of that, and I point to this, that we've grown to such a regional hospital in so many ways that we see patients coming from inside, as well as our employees. If we looked at our employee graph, we have a lot that drive in to work for us as well. So as we continue to grow, that's something we'll have to continue to look at. As far as our payer mix, I want to point to a couple things to set the stage for what we'll talk about today. Right here you can see in our market area, and that's really the market area I just showed, we break it up into our payer mix. Commercial managed care, that's your typical Blue Cross, United, whatever else it falls in that. And then Medicaid, Medicare. Medicaid is for the low income, Medicare is for 65 plus or a few disabled. And then you have your other self-paid. And you can see in our market, we've had a 21% drop in that commercial managed care, which is where we make our money. You can see a growth in Medicaid and a growth in Medicare. When you look down here at our payer mix, we've actually grown some in the commercial. We've seen a large increase in Medicaid and Medicare, and roughly those two alone make over about 50% of our payer mix. So 50% of our revenues come from government, either state, local Medicaid, or national Medicare. So that I'm laying a context for what we're dealing with as well, and that's something that's continuing to grow. When you look at Medicare, a lot of folks don't understand we lose money on Medicare today. Across the system, we're about 5.67 cents we lose on every dollar. So when that's 44% of your business, you're already losing money. Medicaid is even worse. We only cover about 80 cents on the dollar. The Medicaid funding is just not there. So we rely on that commercial insurance to have funds as a not-profit to reinvest, to employee salary increases, that sort of thing. The other thing is in the commercial market, and I'm sure by now everyone's gotten their premium increases for next year. They're all going up for multiple reasons. But one of the things we're seeing is that these high deductible plans are coming out. Everyone's getting a higher deductible that has to pay out of pocket. That is one of the fastest areas that we're not collecting money in. And the reason being is people don't always have $5,000 just laying around, if they have an unexpected illness or something to that effect. We've actually started to see this past year some $25,000 deductible plans coming out in the market. Now, I don't know about y'all, but that's fairly expensive. And then we've been dealing with the state of Georgia bed tax. About 2.5 years ago, the state of Georgia they had a gap in their Medicaid coverage. So what they did, rather than raising taxes, they taxed the hospitals. And I guess because hospitals don't vote, but people do. And so we've had to pay into this about $3 million every year. And the reason why they did that is that for every dollar the state spends on Medicaid, they get matching funds back from the federal level. And so the net effect is, for what the hospitals are being taxed for, we're getting more money back from the federal level, which will cover that. Now, the problem for us is that while we are paying about $3 million a year, we only got about $1 million more back in increased Medicaid funding. So it's about a $2 million loss for us every year. If you look at like children's health care, they've had a huge swing because they're almost all Medicaid, just being children. So this is coming back up into the session this year, and it's going to be an interesting debate because of the state still is having trouble funding Medicaid. And I lay all that because that's kind of our current scenario. One of the things when we were in Williamson, Tennessee, they talked a lot about their collaborations, what they're doing for population health management, working with Vanderbilt. But I don't know if they really kind of explained why we're having to do that, because we're doing the exact same things. They're very similar. And really, we've got the Affordable Care Act that's coming down the road. And by all means, I don't want to get in any kind of political discussions over this. But I think there's some really economic realities that are happening. And I've been telling everybody at the hospital, it doesn't matter whether that plan passes, another plan passes, we're going to get paid less. The federal government cannot continue to spend what it's spending on health care. So we've got to get ready for it. The problem we've had, though, is that there's still so much uncertainty around the details of the plan. And when you look at what's in the plan, the length of it, there's a lot of detail that's being written by CMS and other entities that are interpreting what the law is supposed to do. We're still trying to figure that out. But I want to hit on three things that are, I think, really relevant to what we're hearing today. First is Medicaid expansion. Now, I already mentioned we lose money on Medicaid. The state is having trouble continuous with Medicaid. And without the bed tax, it could get even worse. One of the things we've been waiting to hear was, the Supreme Court came up with a ruling that states do not have to participate in the expansion of Medicaid. Up until yesterday, we weren't sure quite where the state of Georgia was going to head. And I haven't seen much press on this yet, but Governor Deal said no to the Medicaid expansion in a conference he was in over in Athens. And this was kind of an interesting dilemma we're stuck in because, on one hand, every one of us as individuals will be paying somehow into, whether it's through our payroll taxes, through our insurance taxes, or anything else, we'll be paying for the Affordable Care Act. So these funds are going up there. If the state decided to expand Medicaid up to that level, it would create additional expenses at the state level that they'd have to impose, up to about $2.5 to $4 million a year. And the governor said, we don't have that money. And so we can't commit to doing that for however long for the next 10 years. The problem is we're still paying in the money, and we're missing out on $33 billion that would come back to the state over that same time frame. So it's really kind of an interesting dilemma that you're stuck in. On one hand, we pay more money individually. It goes to the federal hopper. Because we're not expanding Medicaid, we're not getting those funds back to match. And it's kind of frustrating mental levels because we're paying it, we're not getting it back. But I understand the governor where he's at. Once when we go there, how can we afford it and make it sustainable as a state? So I don't know, and we'll talk about this in a second when we look at what this means for us and how we're preparing for it. The next thing was the health exchanges. One of the things that came out 2 or 3 weeks ago was said the state of Georgia will not participate, will not create their own state health exchange. And a year ago I would have said I would have preferred to see the state do this rather than at the federal level. The problem is there's still no definition around how this works at the federal level, and so we don't even know what we're getting into. So we're going to be participating in the federal exchange, and even as a healthcare provider, we don't know the rules of that, what the plans are going to be like. We anticipate more high deductible plans, but again, it's still undefined yet. So it's something we're watching for. The next one is the increase in premium subsidies for those that are incomes up to 400% of the poverty level. And this is where the federal government will have income subsidies that help people go into these exchanges to get access to insurance. So when you look at these three things, this is what if we look at the non-Medicare population, currently we have about 19% uninsured, and that's very similar to what it is in the state of Georgia. With that, the Affordable Care Act would take us to about 8% uninsured. The Medicaid expansion would have taken us from 12% up to 18%, and then the exchanges would have gone to up to 18%, leaving, and this is closing the gap of that uninsured. Because we in the state of Georgia will not be in the Medicaid expansion, we're going to have a lot more uninsured still. So we're not really addressing the insurance issue. And so what that means, you can see just briefly where they're trying to get the different percentages of folks into the increased insurance coverage. So of the 31.7 million uninsured, these 44% are not eligible for subsidy assistance. This 35% here is covered through Medicaid eligibility expansion, and then these are through the exchange. So this is not going to happen. So we're only going to get some additional coverage through that, through the program. The reason we were watching this is because Medicaid expansion, if you look in Massachusetts where they implement a similar plan, there's not the doctors, there's not the providers to take care of even today. And so what they see is they come through the ER, they have to use the ER more. And so we look at this, in Massachusetts, the average ER use per 1,000 was 488. Those that are in their equivalent of Medicaid, there's a much higher utilization rate. So, because all of a sudden they have the insurance, but they can't get in to see the doctors because doctors aren't accepting new patients under that. And then there's Medicare. We have about 7,000 folks coming on Medicare every day. And that's a fairly conservative estimate. When you look at our community and what we saw this morning with the 65-plus population growing, that's continuing to grow for us. And keep in mind, that's the one also said that we lose money on. So it's kind of a daunting task when you look at it. But what the government is trying to do within this, they want to get, it's kind of a larger role for government as far as how they control Medicare spending. And there's three ways that they're really doing that. One is value-based purchasing. There's payment bundling and accountable care organizations. Under value-based purchasing, and we've started this for the first year, this is already in effect. This was a part of the Affordable Care Act. It's kind of a pay for performance. So what they're saying is they're withholding money that they paid to us a year ago. And they're splitting up 70% of that is based off core measure scores. And these are quality indicators like, did you give an aspirin upon arrival for a heart attack? Did you give, and it's as much about the documentation of it as is did you actually do it or not. Leonard and I were talking about that because his wife, I think he learns a lot from his wife about having to deal with this at the hospital. The other part's on satisfaction. And so they're withholding money, and they're going to redistribute about $850 million a year through this program. Now, right now, our indicators are that we will get back what we're holding almost dollar for dollar of where we stand right now. But we've had to invest hugely in staff, documentation issues, and is it impacting the quality of care? I think it is, but it's kind of like when I was talking with Leonard, it's kind of like when you got these test scores and you're measuring to the test scores, are you improving the education of your children or not? It's very similar with that in healthcare now, where we're headed. We also, on that last slide, we're now not being paid for readmissions within 30 days for certain diagnoses. So like congestive heart failure. If a patient's discharged, they go home and are readmitted within 30 days, we don't get paid for that anymore. The interesting thing with that is we started a heart failure clinic, and if we have a patient that's in the clinic that's that is working with us, we have a 0 readmission rate. Where we're getting penalized is those, and not to be facetious, but those that go home and drink beer and eat pork rinds and then end up back in the ER wondering why they're sick. That personal accountability is something we're going to struggle with, but we're taking the brunt of it. Then there's payment bundling is the next thing. We're having to, this is to force a lot of the doctors and hospitals closer together. What the government's going to do is say, we're going to pay X amount of dollars, and y'all take care of that, say, orthopedic patient, pre and post. Right now, they pay the doctors for what they do. They pay us for what we do. Now they're going to say, here's the money, y'all divide it up. So it's a whole new world of how we're going to be operating. This hasn't quite started yet, but it's coming down the pike within the next year or so. There's some pilot projects that are out there. And what it forces them for us to do is, how are we going to make this profitable? And it's going to be looking at utilization of services, utilization of tests, which I don't know if it's the right driver sometimes for that. Then the last one is what you might have heard a lot about, accountable care organizations. And I've got a picture of a unicorn because we hear they're out there, but no one's ever seen one, And I think accountable care organizations kind of fall into this because what they basically want to do is say, we're going to give you X amount of money in addition to the bundle payments to take care of a population. So say, if, for example, they said for Piedmont Fayette, we want you to take care of the Medicare population in Fayette County. Here's your money, go do it. And that's the theory that we would then reach out, we would help, prevention and all that kind of stuff. The problem is the patients, those Medicare patients, don't know that. They can still go downtown and receive care. They can still come, to us and receive. There's no, again, accountability tie back in there, and this is something people are really struggling with. I think it's going to be interesting to see. There's a lot of pilot projects that are out there now, and we're trying to get into some of this as well. But it is very hard to figure out how to make it work. So what's the answer? I think first and foremost, we cannot let outcomes and patient safety suffer. We've come too far in our healthcare field as far as outcomes and some of the great things we're doing that we can't start cutting back to the extent that we're putting things at risk again. We've got to learn how to redefine the traditional care model. One of the things you're going to hear about a little bit is some of the partnerships that we've realized we have to form in the community. We have to work closely with the Fayette Care Clinic. That whole discussion about ER utilization. Do they have insurance or not? How much are we going to have in this county? What's the Affordable Care Act going to change? They're still going to be uninsured. There always will be. Even with that fully implemented as well. We even know now that the Medicaid expansion is not going to be there. We're going to still have a huge problem. And it's up to us to partner together, figure out how we work together to make sure we keep them out of the ER and how we support the Fayette Care Clinic and the Healing Bridge Clinic and others like that can really help give somebody a home and access to the care. The other thing, real quick on the traditional care model, we opened up an immediate care center down at Yorktown to try to give additional access, but part of that was also to have some practices in that building that could expand Medicare coverage. We have physicians in this community. There's only 1 or 2 that I know that are taking additional Medicare patients. We got to find a way to do this. So we've got 2 physicians down there. We've got some mid-levels we're putting in there, some PAs. And we're just saying we've got to figure out how to do this. And it might mean that you've got a PA you're seeing more regularly, but if it's the only way we can do that, it's better than nothing. We've got to find ways to reduce costs through efficiencies, and this is both locally and as a system. If you notice with Piedmont, we've got Noonan, we've got Henry, we've got, that's for a reason. That's just responding to the market, to how we can, whether it's supplies, managed care negotiation. We've got to find ways to not duplicate services as well, and that's really what Williamson and Vanderbilt were doing. And I've had some subsequent consequences. You know, they were talking about how they're trying to keep all the OB patients, you know, at Williamson. The story behind that was Williamson was already taking them. I mean, because in that community, people didn't want to drive in. And so what they realized, though, is that if they could work together, transfer particularly level 3 babies and coordinate the care, that they could actually make it more efficient. And so that's what's driving a lot of this as well. Information technology is another huge thing that's going to be coming down the road. We're actually going up throughout Piedmont on a huge brand new medical record system called Epic. This is going to be kind of it's going to be painful to go through, but what it's going to do is going to, if we have any doctors in the community, PPG or whatever, that have an electronic medical record and they come in our ER, we don't see that now. This completely integrates it. So we'll be able to see what tests were in the office when they come in the ED, if they had x-rays already, and then if they are transferred downtown or they come from another facility within Piedmont, we'll have complete integration of records. And that's a great way to standardize care, number one, but number two, duplication of tests, duplication of ordering. I mean, how many times do you go to your doctor, they order blood work, and you go, come to the hospital, we got to order more blood work because ours is different, whatever. It's going to standardize that completely, and that variation of care is where we're going to not only, I think, have better outcomes, but we can start controlling cost. And then also we can start managing health population. Because right now, it is hard for us to know if within a practice, if patients that have diabetes, how many times have they been to the doctor? Are they getting their follow-up? Daily checks on whatever else, and coordinate that and be proactive with it. We react right now, so we got to get out in front of that. About this time next year, Piedmont, we're going to be rolling out our own health insurance plan. This is a new thing as well. So we could go compete with the Blue Crosses or the, you know, but one of the neat things about this is one of the first things we can roll out as a Medicare Advantage plan. And if we can come into Fayette County, roll that out. If you think about with our demographics and our population, and then we've got primary care physicians ready to start opening up, which is why we're trying to pilot how to make it work now. One of the things that happens with like the existing plans is that a lot of the managed care companies now are taking money off the top. I mean, they're making money off Medicare Advantage. Meanwhile, for Medicare, we lose money. For Medicare Advantage, we really lose money, and doctors don't want to deal with it. So if we can put those back into getting doctors involved, you know, back in the care where they want to see them, we can increase access to them, and then manage their care through our technology systems better. I think we can start having an impact. And so I'm excited about that. I think that's something, a different way of looking at this world that we haven't in the past. I think we've got to get into the utilization of services. And I have death panels there because one of the worst things that happened through the debate was when Sarah Palin brought up death panels. What it did, it completely wiped out any rational conversation over end-of-life issues. There was actually some good legislation in there that Isaacson was actually putting in about, you know, encouraging, we got to have living wills. I can't tell you how many times we have an extra 3 or 4 days of an end of life for a patient because, and this has actually happened once, where the girlfriend and the wife argue over what needs to happen to the guy. I mean, it's a very, it's very expensive. And so there's a lot of that out there that we've got to start, you know, understanding what is that. Also, utilization services. RER physicians, you know, if you come in and you have, you know, a unspecified diagnosis, they're going to run every test they can. Some of them will tell you, I'm doing it because if I don't, I'm going to get sued. So tort liability is a part of that, but also is really the driving the conversation. If you order that test, is it really going to change how you treat that patient? And a lot of times they'll tell you no, but I have to because that's how I was trained, or that's how, you know, for that small percentage of, you know, and it's just, again, it's back, we're driving up the cost and we're all paying for it. So that's a very tough conversation. I think we can do that, though, through some of our technology as well. Physicians and hospitals, we're having to find how to be financially aligned together. Physicians are very independent, autonomous group. A lot of them over the years have come to us, want to be employed now. Some of them want it, some of them don't. But we've got to learn how to, particularly if we're going to be given money and hear y'all dole it out together. Oh boy, And from my aspect, it's like, okay, there's an orthopedist, there's a cardiologist, there's multiple fronts there to try to work with, and how do you make sure that you're not losing sight of that patient care? I think we were already in the transition from a pay-per performance to population health management, and that's where we get out to the health of the community. How do we keep the community healthy? I always tell everybody, if we could cut the obesity rate in this country by 50%, I don't know if we'd have a healthcare crisis. Easier said than done, but how do we really change lives and how do we manage that? Because when you look at the spin-offs of a lot of this stuff, it's really driving up the cost of how we care. The last thing I want to say is, public perception and personal accountability, I think, is still absent. I was at church about a year ago, and a guy, he was telling a story about he just had to spend $400 on a chip in his truck because the windshield wiper just kept going like this. Okay, he was laughing about it, just flipping. And then right immediately after that, he turned to me and said, "Now, oh, Michael, y'all had my daughter in the ER. She's been throwing up. Y'all gave her some IV fluids and all that stuff. And it was great. And I got a bill for like $350, and I don't have to pay that, do I? I mean, y'all just write all that off, don't you?" And I said, "You just spent $400 on a chip for your truck and didn't bat an eye, but you're going to complain about that, for your daughter, that doctor's bill?" And he looked at me and he said, "I'll shut up." Because he realized that, and I think we all do that what's it, personal responsibility as far as healthcare is expensive. If you look at how we prioritize our expenses, house, food, and you go down there, I bet, cell phones and everything else we all do. Healthcare is not always up on there as far as a routine bill. And I think we've got to change some of that. Even if you jump back, and one of the things that I think Cheryl, I commend them on what they do. If you go back 50 years ago, 75 years ago, that's what a lot of healthcare was. It was care clinics. It was charities that started hospitals. It was, we took care of our parents. We took care of, we've gotten away from that as a culture. And I don't know how you solve that. But when I see a family drop off their mother in our ER because they're going on vacation, I've got a problem with that, and there's a mindset that we've got to work on through this, and it's not just it's everywhere, but I think that's where it's important to me that the partnerships are there.